Hi everyone, I'm Helen Chatterjee. I'm a Professor of Biology at UCL and I'm one of the co-investigators on the March network.
Hi there, my name's Mah Rana and I'm one of the researchers on the March network group, Arts and Crafts Mental Health Specialist Interest Group. I think the pandemic had a very kind of disruptive and dramatic effect on people who were relying on community assets. And with the first lockdown, when things were shut down very quickly, I think it took a while for kind of community assets or people in those sort of organizational roles to kind of rethink and adapt to how they could provide different types of interventions. But I think for some people, it was still very disruptive and quite dramatic in terms of the effect on their well-being.
It was really the suddenness that all this happened and the impact on those individuals that were reliant on services and those services themselves. I guess what that did, though, is really highlight what the value of these sorts of assets and resources, community-based sources of support are. And when they're suddenly removed, that's when suddenly, we all value them. But then it's when I guess that the wider world started to recognise, how important it is to have access to community spaces like Mah says, day centres, but also parks, outdoor spaces, our museums, our libraries. Suddenly, these restrictions meant that those sorts of assets and resources were not available to us.
I think kind of for me also from a personal aspect, at the time I was a carer for my mother and she was receiving, she was going to day centres 7 days a week, 7 hours of kind of social and community care. And then it stopped overnight and it was reduced to, the day centres were very good in trying to kind of adapt to it, but all they could initially put together as a package was 15 minutes of care per day. So dropping down from 7 hours to 15 minutes was, for me, kind of caring for my mother, it was such a dramatic, and looking back on it, it was quite brutal for people who are very reliant on different types of care just for kind of day-to-day living. And I think for a lot of people, things kind of spiraled very much out of control for quite a long time.
Well, the great thing is we already had contact with huge numbers, hundreds and hundreds of organisations, individuals, and NGOs, charities, who were already serving their communities in a multifarious set of ways. And very quickly, we scrambled and put together the creative isolation pages, thanks to our wonderful March Network team. And that was both self-populating, so people would contact us and let us know what they were doing, but also doing a huge amount of desk work into looking at how people were adapting and what was available. And it just really spiraled and grew. And as you can see, that there's a huge plethora of what community organisations did in the face of the pandemic. I think, in many ways it shows how agile and responsive those sorts of organisations can be, really in the face of extreme adversity. Yeah, so the project really came from the work that we've been doing within the March Network and wider with organisations like the Culture, Health and Wellbeing Alliance and many of the partners and organisations who are represented within the March Network, to really understand how those community assets, resources, organisations had responded to the pandemic in terms of what types of resources, interventions, programmes they were now offering, how they'd adapted those resources, and then critically how participants were engaging in that. So we've been doing a whole range of surveys, desk-based research, and really critically lots and lots of interviews, linking up both with participants, including general participants like ourselves who might have been doing stuff online or going out and about and getting access to stuff that we wouldn't have normally, and particularly people who are shielding or in vulnerable categories. And then also critically working with providers to understand what their needs, what their challenges, and particularly what sort of barriers. And that's really where Mah and her work has come in, trialling really more creative approaches to really get to grips with understanding particularly people who are vulnerable, and shielding and what their lived experience is.
And I think it's great, as Helen was talking about, all these resources and kind of databases coming together. But I think it's also really important to think about how these kind of adapted programs or resources are kind of delivered or used by participants, and kind of understanding what works and what doesn't work, and also understanding the needs of kind of individuals within a group, because they can be very kind of nuanced. So people might have kind of similar kind of groupings of common issues, but how you experience those can be very sort of nuanced and complex and very different from another person. So kind of understanding how those sort of interventions can be applied in a kind of productive way.
I guess the really critical thing specifically for the research has been that there's still many, many barriers that a lot of people face, both at the provider's end of the spectrum and then also for participants in connecting. And those are things like the digital divide and those digital challenges, but also just in terms of physical access, psychological barriers, for making this sort of work more accessible. And what we've seen is brilliant examples from many organisations and individuals like Mah making a huge effort to reach out. And now it's about how can we spread that really great practice, you know, the lessons that they've learned, working with new partners, for example, local authority risk registers or safeguarding teams, food banks. We've seen lots of arts and cultural organisations working just with different sorts of organisations that they would never have thought of before, and finding new ways to reach hard to reach audiences. So we want to spread that good message, I guess. I think there are opportunities ahead. So, for example, you know, with the changes that are coming about in terms of health and social care architecture, so the integrated care systems, there are opportunities there to do things differently. So we've got to seize those opportunities, and that's where the kind of March type and community COVID research really slots in, because here we're talking about the development of what we're calling creative health partnerships. So instantly through the integrated care system, the NHS Trust, the primary care networks, all those different health, social care and community organisations have got an opportunity to work together differently and disperse the funding differently. And so it's changes to those models, both at a preventative and a remedial level across public health, that they need to happen. But that's where we need the research to slot in. And I think the challenge has been that this sort of community-based research that we're talking about now, yes, it's been around for a long time, but it's not been speaking to this systems level approach that we need to slot it into. What we're trying to do is operate at that higher national policy level so that we can then filter it down to these more local and regional levels, so that we can understand how to make changes at these very local levels, which is the only way the ecosystem can change. And that's quite a new way of using research. But I think there's lots of great opportunities around that, and we've really got to seize that.
Yeah, I think it's really important to kind of find sort of directives and avenues to kind of support people with lived experience to become researchers as well. And I guess that's kind of my background. I mean, I'm now doing a PhD at Birkbeck, but I'm the driver for doing the PhD was my lived experience, and kind of recognizing that my voice wasn't so readily sort of visible in research. And I think that's kind of happening a lot more now, that people with lived experience are moving into research so that they can articulate their experience in a way that is different from somebody who's an outsider researcher. So I guess in a nutshell, it's about having different types of researchers, outside researchers and inside researchers who can work together and bring kind of different nuances and understanding, but also maybe think about how you then work with people who are perhaps kind of, you know, very vulnerable or at risk, and kind of understanding how you make those connections or kind of build trust so you can do the research that is meaningful for the research community, but also for the people who are being involved in the research and being, you know, the people who are the participants. So they're not being, for want of a better word, kind of used for data, but they get something from it as well and contribute in a sort of meaningful way.
I think one thing is thinking about health inequalities in the sort of Marmot model of these wider social determinants of health. So at the minute, lots of our research funding is very siloed still. Lots of researchers are still very siloed, but we need to be working directly with those community organisations. We need to be working directly with local authorities, health and social care providers, alongside the community organisations. So at the minute, those organisations, sometimes are connected in with research projects, but often the research is quite separate. So we really need to have research funding that enables researchers to be embedded within community organisations, to be embedded within local authorities. And that's quite a new way of working, particularly for a lot of research individuals and organisations like UKRI and NAHR. They're not used to funding that much more interdisciplinary type of approach. So really funding through communities has to come and be funneled in through a different way so that they're benefiting directly from that research.